I'm going to cover sort of risk models in general, just like I did for guidelines. I don't want to be hypercritical of risk models, but there are things to take into account and evaluate their reliability in other fields, then look at the aortic dissection, and then talk about surgeon experience and intuition, and then finish it up with some of my experiences with clinical status and long-term outcomes. First of all, if you look at the diagnosis for acute aortic syndromes, we talked about that a little bit earlier. You look at how they came up with the formula 1, 1, and 1. So you can get a score of 1, 2, or 3 for the aortic dissection detection risk score. If it has 1, you're intermediate. If you have a 2 or 3, you're very high likelihood. But if you look at what the majority of the intermediates were, the majority were abrupt onset of pain, severe pain intensity, or ripping or tearing pain. And I would conjecture that if a patient comes in the emergency room with any of those 3, regardless of anything else, you're going to get a CAT scan. It's probably quicker than, in my emergency room, it's quicker to get a CAT scan than a D-dimer. But, I mean, when looking at sort of questionable cases, I think they can all become relevant. Let's look at the risk models that have come for aortic dissection. This was the IRAD that I was asked to address kind of for the, at least in part. And there's 2 models, the preoperative assessment and then model number 2, which I'm not even sure why they had developed it, which includes intraoperative findings, because that's not going to tell you anything except what's the likelihood of your patient surviving after surgery, I guess, in retrospect. But why make a risk model? Again, we heard all these arguments before. Is it to defer surgery on someone who's older or may have comorbidities, to improve our decision-making and the decision-making of the family? It's not really beneficial in young patients, I don't think. You're going to operate on everyone who is considered young, and obviously that definition changes as the age of the surgeon gets higher, I think. But if you look at model number 1, it's got the classic findings in it. Older age, obviously, AVR with a reduced surgery, hypotension, shock, or tamponade, which obviously makes the patient at higher risk because they come in at higher risk. Migrating chest pain, again, tamponade, malperfusion, or coronary problems. And if you look at an example, a 77-year-old woman, they have a scoring system with migrating chest pain, tamponade, pulse deficit, ST elevation, has a 61% mortality. You're going to go to tell the patient they got a 61% mortality, and compared to what? 95%? If they came in with that, it's probably 100% with medical therapy. So I question sort of what are we going to do with the risk model in that particular patient. And if you look at the risk model number 2, tamponade and EKG changes are no longer included, but what's included now is shock in the operating room, right ventricular dysfunction. Doing a hemiarch is better than an arch. Obviously, that implies less extensive disease generally, or having to add a cabbage, which generally involves a dissection that involved one of the coronaries. And again, you take a 54-year-old gentleman in shock at presentation who is still in shock in the operating room, hemiarch, cabbage, 31% mortality rate. Really, the only thing that benefits you is comparing your outcomes, I guess, with what you expect. So I'm not really sure, as a preoperative assessment tool, it's really of much value in aortic dissection. They're reliable, though. They both predict mortality reasonably well. Now, if you look at the IRAD compared to Gerada, they're quite similar. They have age, they have shock, malperfusion, and prior cardiac surgery, the kind of things that you would predict. There was a couple of studies comparing Gerada to the Euroscore too. However, Martin Cerny made a commentary about these papers, making note of the fact that in order to come up with a Euroscore in dissection, they had to modify the Euroscore, so it's not really a Euroscore. They substituted malperfusion of a vessel or cerebral or coronary for PVD, CVD, and other things within the Euroscore. So what's the impact of specialization? We heard about the aortic center. This was Mo Bashir's article looking at the UK database, 1,500, lots of different surgeons. And he found that the operative mortality, if you did less than 4 cases per year, was 19%, greater than 4 cases per year, 13%. So there's a difference, maybe. But again, probably the ones that are doing over 4 cases a year are all seeing transferred patients that have made it through the transfer, and so have maybe some of them have been selected out. And you can see the majority of the cases were done by somebody who did less than 4. So it's kind of hard to sort of say that that really holds validity. The group that did perform more than 4 surgeries did have better long-term survival. It wasn't the most important factor in predicting long-term survival, but it did have an odds ratio that was significant. Next, if we look at, again, there was a study out of Yale where they actually, in a 10-year period, only performed about 120 type A dissections, which is not too many. But they did find a difference between those that were performed by the aortic specialists, which was 3 of the surgeons, versus the non-specialists, which were 5 of the surgeons. Pretty significant survival difference in those patients, 7% versus 17% in the non-aortic specialists. And they, based on these findings, changed their practice at Yale. What about surgical intuition? What about my impression of the patient? Is that important? Does that play any relevance? Well, this is general surgical patients comparing NSQIP, which is the American College of Surgeons risk calculator. They found a difference that the clinical predictors of the risk score were better than the surgeon. But look at the procedures that predominated: laparoscopic cholecystectomy, laparoscopic appendectomy. Those are procedures that have 0 risk. So really, what's the relevance of this paper at all? Let's look at one, though, that's a bit more relevant to emergency cardiothoracic surgery. This was emergency general surgery, and the Potter score was a score developed for emergency general surgery. And the NSQIP also has some modifiers where a surgeon can say it's going to be higher than what the risk predictor says. But if you look at the surgeon risk, the surgeon over-predicted all the risks of mortality, renal failure, and prolonged ventilation, while the risk scores underestimated mortality and definitely under-predicted renal failure and prolonged ventilation. So in this particular circumstance, the surgeon's views were better. And let's look specifically at type A's. This was a paper out of Guangzhou, and that was 161 patients that were all done in 2021. And the surgeon rated 1 to 10 how likely he was the patient was not going to make it. And if you compare the patients that survived, they had an average score of 5. And if you look at the patients that didn't survive, they had an average score of 8. So the surgeon definitely, and there was a significant difference between those two groups, the surgeon definitely could pick out the patients that weren't going to do well preoperatively. When they compared their intuition to the Girardi score, it was pretty similar. Maybe, and then when they combined the two, it actually had even improved prediction. But malperfusion, I think, is probably, I find, the most important. You look at the Penn classification: no ischemia, local ischemia, generalized ischemia, or both local and generalized, meaning a patient in shock who maybe doesn't have flow to their leg. You can see that the mortality rate goes up significantly just based on the degree of malperfusion. And that's just predictable. I mean, that's just, makes common sense. When you combine malperfusion with acidosis, we found in a study that I did with Jennifer Lawton that malperfusion had a substantial impact. I'm going to show you a graph here, or a chart here. When the base deficit was greater than 10, looking to the right, base deficit was greater than 10, and the patient had abdominal malperfusion, 100% mortality. When the base deficit was greater than 10, and with any sort of malperfusion, 93% mortality. So we found that that base deficit can certainly predict a bad result. And it was the most important predictor of operative mortality over all the other factors in that study. So we came up with some sort of a way to assess. I'm not going to show you that in detail because I'm not 100% sold on it, but that's the patient that comes up with a malperfusion you really need to evaluate. But what's ultimately most important? long-term outcomes. And we looked at what impacted long-term outcomes and found very interesting, looking at reoperation, that non-resected primary tears, Marfan syndrome. Most importantly, though, was elevated systolic blood pressure at late follow-up and the absence of a beta blocker. And I'm going to show you a couple of graphs. On the left, patients who had blood pressure of over 140 at follow-up compared to under 120 had a substantial difference in reoperation, as did the patients that were on a beta blocker versus those that were not. So these two things are very important to keep in mind long-term. And we're also looking at late aortic growth. We measured and found that aortic expansion, if you look at the independent predictors on the bottom, again, was most significantly affected by increased blood pressure at late follow-up. So I think it's important to have medical therapy for these patients long-term. And again, depending on how big the aorta is, kind of gives you the timing of how often you should get a repeat CT scan. Anybody who's got an aorta of 5 centimeters and you wait a year, they're going to have growth in their CAT scan. So that's probably a patient you'd want to follow more frequently. So risk models for diagnosis, some of them are reliable, but how do we apply them and when is it relevant? Surgeon and experience and intuition certainly play a role, and maybe it's long-term outcomes we should be looking at as opposed to 30-day. Thank you very much.